So at least terminology you should know about that. Prosthodontic is prosto mean artificial dentic teeth. There's a branch of dentistry that deals with replacement of missing teeth. Prosthesis is any artificial replacement of any part of the human body. You can hear like eye prosthesis, ear prosthesis, nose prosthesis, but the prosthodontic is teeth prosthesis. So when we extract teeth, when people lose their teeth, the bone will change. So we have different anatomy and different even physiology, and different space, different dimensions, all this when we extract teeth. There's different landmarks. When we set up teeth, when we make dentures, we should know where we put the pressure, where we put the teeth, where's the tongue going to be located. All these, you should know about these. And you remember them. Because when you set up teeth, fake teeth, they should be located not exactly in the same position of the real teeth, but they should be in the perfect position. You should eat, can talk, can smile, and the denture will be located in perfect position. So dentulous means people who have teeth. Dentulous. When they lose their teeth, they become edentulous. Edentulous with the E, condition which mouth is replacement, missing teeth. So there's partially edentulous, missing a few teeth. That's partially edentulous, the first one, or completely edentulous. This is George Washington dentures. They made it from ivory and special glue, and they put it with the elastic. So it was very uncomfortable. These are. So this is the lips, vermeil borders. And if you put the teeth too much forward, the lip was like very ugly. So when you set up teeth, they should be in the perfect position. So the lip is not over pushing forward or backward. The philtrum is the brushing here. And if you push the teeth forward, it will be flat and it will look very ugly. And if you push it backward, it will be like the breast. So you should know how it looks like, the philtrum. And this is the angle. Can you see? It should be 90 degrees. The angle between the nose and the lip. Imagine if you set the teeth forward, too much forward. It looks so ugly. People like overbite. Or you push it backward, they look so ugly. So this is the range, about 90, 95, 85. That's a normal. Nasolabial sulcus. This is pressure here. Nasolabial sulcus. They call nasolabial sulcus. So this one, when there's a support to the lip, it's normal. When there's less support, the sulcus will be very, very, deep. There's a vertical dimension. Vertical dimension is the measurement between the chin and the tip of the nose. Okay. And there's three types of jaw relation. There's a jaw relation with the mandible forward. That's class 3 when the mandible is so much forward. When the mandible backward, it's class 2. And the normal, it's a class 1. That's a class 1. Normal. And this is class 2, that's class 3. The jaw relation. There's a teeth relation also, dental relation, class 1, 2, 3, which is the lower teeth, and this is upper teeth. There's at least 2 to 4 millimeters. The upper teeth always cover the lower teeth. I think we have this. Can you see? The maxillary teeth cover the lower teeth. At least there's 2 millimeters between the lower teeth and the upper teeth. So this 2 to 4 millimeters. It's normal. 2 to 4 millimeters. If it's more than 4 millimeters, it's class 2. If it's reverse, it's a class 3. Modulus. Modulus is the angle of the mouth, the corner of the mouth. Patient talks, so we should be respected. Don't let the denture, if the denture is not fit, the modulus won't work very good. The denture will fail, the patient couldn't talk. It's the relation between these muscles and the denture. So this is when you extract teeth, that's what they're remaining. Let's talk about the maxillary. This is the maxillary. When you lost the teeth, you have all these remaining. There's no teeth here. There's anatomical landmarks. There's a frenum, labial frenum. If you feel it, it's a tissue between the residual ridge, remaining ridge, and the lip. And when you put the denture, you should put the denture over that frenum because it will hurt. Sometimes the frenum is too high. You have to send it back to the dentist. They cut it, interfere with the denture. Labial vestibule is the space here. And I will give you one denture. This is the upper. This upper video. Yeah. So this is the vestibule. You see, this is the vestibule here. This is buccal vestibule. Okay. This is labial vestibule will be here. Buccal vestibule. Hamillus notch. Hamillus notch here. It's a bony structure on the back of the maxillary. Sometimes you feel it, sometimes you can't. But this you can't put the denture beyond that extension. It's the posterior part of the denture. Soft palate. This is the soft palate. This area. This is hard palate. Okay. The denture will be stress in this area. Denture experiencing stress area. So this is a root area. Root area on the front is a rough area. It will help to stabilize the upper denture. The tuberosity here is a bulge of bone. Sometimes it helps us to support the denture, and sometimes it's too big to interfere with the denture. Sometimes we have to send it to the dentist to cut it. But most of the time, it's good bone support denture, so it's good supporting area. Hard palate is good supporting for the denture, and there is a relief area. Relief area is where there is the denture cannot put all these areas, like incisive papilla. Incisive papilla here, like it's an opening inside the bone. There's nerves and arteries comes out in the middle of the ridge here. You shouldn't put too much pressure there because there's a nerve and arteries there. Median palatine raphe. Here, it's the maxilla. Usually maxilla. Actually, it's two bones. They meet together like this in the raphe in the midline. So this is the midline between them. So, and this is like bony suture, and there's the thin mucosa. So if you put too much pressure on it, then the mucosa will cut because there's very thin mucosa. And if you put too much pressure on it, it will like damage the fabrication. So in the midline, you shouldn't put too much pressure on it. Torus palatinus. I will show you the torus palatinus. Sometimes people have extra bone, would be the middle of the bone, of the palate. They call it torus palatinus. Fovea palatina. You know, we have all salivary gland. There's a major salivary gland, the parotids, and they secrete saliva. There's also, we have minor salivary gland. And the lip. If you flip your lips like this and look at your mirror, after a minute you see the saliva. This is a minor salivary gland. So in the roof of the mouth, there's a major salivary gland. They have two openings. They call them fovea palatina. This is 1, 2. These are the opening of salivary gland. We use them to find the midline because they are located in the midline. The problem when people lose their teeth, they lose their midline. So usually the dentist will find the midline. They have old costs, but if they couldn't find the midline, we have to find it. So we can use the fovea palatina would be here, and then the incisive papilla would be here. We can make a line. They can find the midline. So when we extract the teeth, when you extract the remaining ridge can be V-shaped, U-shaped, flat, rounded. What do you think is better to keep the denture? We need the denture. U is better. V is okay. Sometimes V is too much V. Sometimes it will crack the denture. So it's better. Flat is the worst because the denture won't fit. So mostly it's U-shaped. We like it. Okay, you must understand anatomy. Of course, you should know the anatomy of the denture. Edentulous. This is upper denture, this is lower denture, lower remaining, lower edentulous area. This is upper edentulous area. This is the buccal vein. Can you see? It's a tissue here. So when you put the denture, the flange of the denture should not impinge on, should not pressure. So you make a space for it. This is labial vein. And the lower half, this is buccal vein. This is another buccal vein. Sometimes they don't have labial vein. They have a little remaining, but sometimes they don't have it. So when we make a denture, there's a few things you need. The denture will be good function. Retention. Retention is mean the denture will sit in the patient mouth and resistant to vertical displacement. So when he eats, the denture will stay there. Stability, resistant to lateral displacement. When he eats and he grind the food, the denture should be stable. And the support. The denture, when the patient eats, shouldn't hurt the remaining tissue. The remaining tissue should be strong enough to support the denture. So there's about the mucosa. The tissue that covers the mouth are called mucosa. We have attached and not attached, and the degree of keratinization. You know the keratin, the skin is keratinized. It's keratin. The mucosa of the mouth, some area are keratinized, like the palate, the gum, keratinized. But some areas soft, like floor of the mouth, it's very soft. It's not keratinized. There's no keratin. Keratin is a protein, make the tissue stronger. So the palate, if you put your finger on the palate, it's strong. When you put finger on the cheek, it's soft. So the cheek is not keratinized. The palate is keratinized. So when you put the denture, when you make a denture, we prefer with the pressure on the keratinized area. The remaining residual ridge, if you feel the residual ridge is strong, you put the denture stress. But you should put it on the floor of the mouth, on the cheek, on the lip. That's okay. Bone contour or retromolar bad area. There's muscle attachment. Muscle attachment sometimes the tongue and the cheek has muscle. So whenever there's muscle, the denture should not extend to the muscle, because every time if the denture extended over the muscle, every time the patient moves their tongue, the denture will fly. So you should know where is the muscle attachment. There's muscle attachment to the cheek, to the lips. So that's what gives us the extension of our denture, where we're going to extend our denture. Saliva. Sometimes saliva, if people with dry mouth, they have that denture experience because we need the saliva. Saliva will make a fluid and will help conceal the denture, stability of the denture. So the saliva is good. People with dry mouth, they have bad denture experience. Sometimes they have cracks, sometimes they have fungal infection. So saliva is good. Disease fact: Candida is a fungal infection. Angular cheilitis. Cheilitis is the lip. If the angle of the lip is inflamed, they call it angular cheilitis. Sometimes when you do the denture is too small, the patient close to wide. The saliva and bacteria goes in their lips, so it causes angular cheilitis. Edentulous fissuratum. Sometimes the denture will cut through the gum, especially the denture, and the patient doesn't have a choice, just to wear it. So the denture, the tissue will make a fibrous tissue around the denture. They call this edentulous fissuratum. That denture should be replaced or managed or adjusted. Distal muscle of mastication. There's temporalis muscle here. That's move the jaw. This masseter muscle move the jaw. Remember this picture we have in the lecture, if you have. When anatomical and dentures, stability support, our master denture, we fabricate is important part of each patient cavity. Patient oral cavity should be mechanical artificial substance. I should change this font. It's not easy. Okay, I don't want you to remember the numbers 14 centimeters, 24 centimeters. Usually the maxilla to give you wide. You've seen the denture. The maxillary denture is bigger than the lower denture because there's a big area, 24 centimeters, cubic centimeters. Okay. This is a picture of when they extract the teeth. they cut the gum, and this is the exposed bone, and this is the socket where the teeth were there. Sometimes patients extract the whole teeth in one session, sometimes due to disease like periodontal disease, and they cut this, and I just want to show you the bone and these sockets. And we have to stitch them. So this is the remaining bone. Look, this is a normal bone with the tooth. The bone is high, but once you extract the tooth, the bone will shrink, get smaller. This is anatomy of the trauma of the edentulous mandible. So the mandible has also labial frenum, buccal frenum, vestibule, buccal vestibule, lower vestibule. The mandible has another vestibule called lingual vestibule, which is the tongue. Lingual is tongue in Spanish. And this is the residual ridge. Can you see this color? It's good support the denture. So the denture will follow all this color. Okay. This is the retromolar that area. Here is a little fibrous tissue, and there is muscle attachment here. So the denture should not extend it over here. Okay. And the denture should not extend it here because here is the tongue. Okay. And on the cheek side, there's a good bone here. They call it buccal shelf. So you can put support here, this brown area. But the extent of the denture should not follow here. If you put the denture here, the cheeks, the muscle of the cheek. So the patient, every time they move their cheek, the denture will jump. And we'll cut them, sometimes they will cut them. So when we give the denture to the patient, after 2 weeks or a week, they will come back. You need to adjust it. Because he needs to adapt to the denture. Everything is new. And so you need to be adjusted. This is the maxilla, again, the picture of the maxilla. This is the supported area where the denture can be supported. This is the green is the relief area. You shouldn't extend the denture over there. This is the ruby area. This is the hammerless notch. Hammerless notch is the extension of our denture. The denture should not extend over this. And the ruby area, it's a good support denture. Denture can be here, okay? So I told you about the foveal It's a minor salivary gland, and there's opening. So it will be useful to find the extension of the denture should not be extended over that, and also you can find the midline. This is the labial frenum, I told you about it. This is the buccal frenum. Oh. And this is the vestibule. So the frenums are tissue, it's a rudimentary tissue. In the rabbit, you can find the frenum, they are like making pouch or good for. But in human, we don't use them anymore. It's just a tissue, flabby tissue. So sometimes they are too overextended, we have to cut them. But this location, we can make the denture like a V shape in the denture flange. We shouldn't cut them. Can you see? This is the denture. We make a V shape to prevent cutting them. This is labial frenum. It's labial frenum, buccal frenum. Why it's repeat? Too many things. Incisor papilla here. Usually when we have teeth, the remaining teeth, the incisor papilla here behind the two centrals. The two centrals are called incisors, so this is incisor. It's a foramen where it's opening in the bone, where nerves and blood vessels will go out and supply the palate. So, and when the teeth extracted, it will be like a bulge. They call it incisor papilla. Incisor papilla, like this is a bulge. We use this to find the midline. We find the midline and we set the teeth on it. This is the canine eminence. The canine is the corner of the mouth. So sometimes as the corner of the mouth, you can find it in the canine eminence. So the extension, what do you think the denture will extend on the back? If you have a mirror and go on the mirror and look at your mouth and say ah, and you can see there's a soft palate moving. Remember the soft palate? So the denture should be extended to the movement of the soft palate. So this line between the hard palate and the soft palate, they call it vibrating line because it's vibrating. So the denture should extend only to the vibrating line. If it's extended to the soft palate, every time they talk, it will fall. So this is the line they call it vibrating line or palatal seal area. Where's the seal there? So the denture should not overextend it there. Just remember I told you that the prosthetic is a bulge in the bone in the back. We use it to support the denture. Yeah. This is the hammerless notch. The denture should not extend to the hammerless notch. Follow. This is the prosthetic. I have multiple pictures of these. This is inside the fibula, labial frenum, buccal frenum. This is when they do surgery, when they extract teeth. This is like 2 weeks after extraction. Look, then when you extract teeth, the bone shrinks. Because when you lose the teeth, you lose the bone around it. So you lose a lot of bone structure. And resorption means losing the bone, shrinking the bone. The maxilla will shrink inward. Can you see the maxilla will shrink inward? The mandible will shrink outward. Okay, yeah, outward. Can you see that it shrinks? The maxilla will get smaller. The mandible, the thickness gets smaller, but goes outward. Alveolar ridge. Alveolar ridge is the part of the remaining bone. This would we can put the teeth. So when we set up the teeth, it should be all the alveolar ridge here. The teeth should be here. So the pressure will go to the alveolar bone. So, well, I don't know what the slide is. Repeat it. This is the maxillary prostate area. Okay. The maxilla. It's good support. It will support the denture. Sometimes if the prostate is too big, sometimes we need to do surgery. They did surgery and cut it. Sometimes like oversized, or there's undercut, we can cut it. Maxillary prostate. This is inside the fibula. Can you see the incisor? It's opening in the bone. Whereas the nerves, there's nerves, and the blood supply comes out of it. So you shouldn't put too much pressure on it. The denture should not put too much pressure because the patient will feel pain. Remember the raphe, midline raphe? This was the midline. I told you the maxilla is two parts, left or right. And this is the bone, the midline, and over it will be very thin mucosa. I want to show you the hammerless notch. This is the hammerless notch. It's a bone notch like this. It's a hook. There's a muscle come from the roof of the pharynx and comes and turn around the hook and make the soft palate. So when you swallow, the soft palate will go up and close the nasal pharynx, so the water will go through your nose. It shouldn't go through your nose when you swallow. So that's the muscle we call the soft palate muscles. This is the incisor fibula. So the incisor fibula, we use it to find the midline. So when there's a teeth, this is incisor fibula. But when you extract teeth, so it will help us to find the midline. Okay? That's why it will help us to find between natural dentition and edentulous area. Palatine ruby, it's a rough area that will help to support the denture. Palatine ruby is irregular because we're very extended bilaterally. Anyway, so this is the ruby area. It's rough. Some people have it, some people don't. Some dentists, they like the roughness. Some people, so when they talk, if there's a roughness in the roof of the mouth, their voice is different. If it's smooth, it will be different because the chamber is different. That's a ruby area with patient with teeth. That's the midline palatine roof. Remember I told you the midline? We shouldn't put too much pressure on this area. The midline of the palate. That's the midline palatine roof. Oh, this is torus palatinus. Some people have extra bone. This is extra bone. Can you see? Extra bone. That will be difficult for you for making a denture. That will be very difficult because the denture will walk around it. So this one, if you lost the teeth and you try to make a denture, you have to send it back to the surgeon to cut this. And sometimes a little bit like this. This is Edentulous, but they have a little bit, they call it torus palatinus. Extra tone. This one we can make the denture a little bit, make a hole, a concavity in the denture. This is another one. You can see it's a bulge. Torus palatinus. This is a very big one. Right? This is the fovea palatina. Remember the fovea palatina? What is it? It's on the back. It's an opening of cerebral gland, minor cerebral gland. We use it to find the midline. Usually it's around the midline, and we should use it to find the distal extension of the denture. The denture should not extend beyond that. That's a fovea palatina. And after the fovea palatina, the palate will change from hard palate to soft palate. So that's our extension. The hard palate will change to soft palate. What type of denture is this guy? What do you call it? Yes, partially dentures. Partially dentures. Okay. This is another fovea palatina picture. This is the Hamlet notch. It's a curved bone, it's a hook in the bone. Remember I told you about the vibrating line? The dentists have special pencils and tell the patient to say ah, and they will mark it. Can you see it? So this is our denture extension. The denture should not extend beyond that. And when they take impression to this area, the mark will be visible in their cups. So you know where is the extension. It's like a pencil, special pencil. Special. And the patient say ah, and the dentist will find it. But sometimes the dentist couldn't find it, or he did find it and you couldn't find it in the cast. You have to find it through fovea palatina to find the extension. But usually most of the dentists will find it for you. We make this line. So can you see when they take impression? The line will show the branch and the impression. They call it the vibrating line because it's between the soft palate and the hard palate. But technically, it's not between the soft palate and the hard palate. Between the movable part and non-movable part of the soft palate. Both of them the soft palate. But the first part of the soft palate is hard enough. Now, the second part is it's movable. So they call it vibrating line, where the tissue vibrates. So the denture should not extend beyond the vibrating line. Okay? And with this impression, so you know where is the extension. Okay, a lot of pictures of the vibrating lines. Can you see? That's the extension of the denture, and this is the vibrating line. And sometimes, well, I'll tell you that later, sometimes in the back of the denture, if there's air goes and the denture will fall. So sometimes the denture will make a little bit dent, like a butterfly dent here. So to make the denture push tissue on the back. So they make like air seal. So there's air, they call it palatal posterior palatal seal. Will seal the denture. So prevent air or mucus membrane or mucus secretion goes on behind it. So that's palatal posterior palatal seal. How many pictures I got? Too many questions. Yeah. Oh, this is the landmarks. This is labial freedom. Can you see the denture? We made a V shape around the denture. Okay? Like we make a relief for that denture, for labial freedom. We have buccal freedom. Can you see? We make a V shape to prevent damage to the buccal freedom. Sometimes we have two buccal freedom, sometimes two, sometimes none. Depends on the patient. And you can see it with their impression. So sometimes people don't have any buccal freedom. This is, and they have, usually they have lingual freedom, the tongue side. And there's, in the back of the mandible, there's a buccal shelf. There's a thick area, so you can, it will support the denture. So this buccal shelf area is good for your denture support. This is another buccal shelf area. It's here, on the cheek side. So when you, it's on the cheek side because it's a little bit cortical bone. Cortical bone is more stronger than cancellous bone. That's why it's called buccal shelf area. That's a buccal shelf area. Retromolar pad. Retromolar pad, it's the end when you extract the wisdom teeth, all the teeth. There is a retromolar pad. Retromolar pad, we use it to set up the teeth. The level of the teeth is 2/3 of the retromolar pad. And the denture should not extend beyond 2/3 of it. Because here, there's a muscle that will extend here. So, temporalis muscle become from, it started from here. So the denture should not extend beyond the 2/3 of the retromolar pad. So retromolar pad is a pillow shape at the end of the residual ridge here. That's a retromolar pad. We use it when we set up teeth. When we reach the setup teeth, the teeth line, this the level of teeth should be to the retromolar pad, 2/3 of the retromolar pad. Okay? We set up teeth, this level of the teeth. This is lingual freedom. Lingual freedom is a tongue side, and the tongue side. Lingula is a tongue in span. So this is lingual freedom. Lingual sulcus. Lingual sulcus is where the denture flange will be here. So the denture should not extend beyond that. It will cut the floor of the mouth. Floor of the mouth is very soft. Sometimes people have extra bone. They call it the prosthetic. And the lingual, they call it torus mandibularis because of the extra bone. Some people have it, like the torus palatinus on the top. They have extra bone. Sometimes you need surgery to cut it. And this is surgery to cut the torus mandibularis. And genial tubercle is the attachment of the muscle here. Sometimes people resolve their bone shrink too much, it reaches to the genial tubercle. But this is genial tubercle. Usually people, when they lose their teeth, the bone shrink, and reach this. And sometimes we make difficulty making denture. Like this. The bone, can you see it shrinks almost gone? And it will show the genial tubercle. But the problem with the genial tubercle is attached to the muscle of the tongue. So if you cover it, the denture, every time they move their tongue, the denture will flip. So sometimes it needs to be surgery to remove. This is the impression for the lower denture. Labial frenum. Frenum, a singular for freni is a singular frenum. Freni is a plural for frenum. Okay. Single frenum, buccal frenum. Limited structure, vibrating line. This is the denture should not be extended beyond these structures. Vibrating line, buccal frenum, labial frenum. All these structures should not be covered by the denture. Lingual frenum, labial frenum, and the lower. That's the same we talked about, retention, stability, and support. Yeah, thank you. Okay. Sure. Very good. Any question? Got it? So we're going to end this and we can start recording.